I thought what I would do is I'm just gonna start by introducing myself a little bit, just a little bit of my history, but then kind of focus a little bit more on this path of how I started to do research on health diplomacy. And then I'll talk a little bit about health diplomacy before COVID-19 and health diplomacy during COVID-19, which is of course something I think a lot of us are thinking about right now. Lydia, did you want to record the session? You're all set?
Yep, we're recording. We're good.
Okay, great.
Thanks.
All right. So, and because it's a relatively small group, I also wanted to say that you should feel free to just unmute yourself or raise your hand and ask a question, because I've got the slides going, so it's going to be hard for me to see if you raise your hand because you're all kind of on the side there with me. So just feel free to unmute yourself and interrupt if you have a question. And like I said, I hope that we'll have more of a conversation really about health diplomacy generally, but especially health diplomacy and COVID-19. All right, so I'm Tanisha Fazal. I'm a professor in the political science department here at the University of Minnesota, although here in my house right now, not at the University of Minnesota. I hope you all enjoy the leaf blower across the street during this talk. After doing my graduate work, my first job as a political science professor, because I've been doing this for quite some time, was at Columbia University. Then I moved to Notre Dame, and most recently, just a few years ago, I moved to the U. So I'm finishing up my fourth year at the University of Minnesota. I still feel like I have to say a little bit of a newbie to the U. I think that I learned more about Minnesota geography in the past month or so than I had in my past 4 years here, just because we were looking so hard to find a place to get a vaccination. But what I want to talk about today is really my research, and in particular this work I've been doing on health diplomacy. But this is something that not a lot of political scientists work on. And so what I'm going to do is talk a little bit about this long and tortured intellectual path to health diplomacy. So that's kind of the bird's eye view of the path. And I'm going to break it down for you to give you a sense of my intellectual trajectory, I suppose, if you will. All right. So the first step in the path is one that started a number of years ago when I was finishing up this book on the left, Wars of Law, which is on international humanitarian law, the laws of war, right? How you're supposed to treat people in the course of conflicts. You're not supposed to target civilians. You're not supposed to mistreat prisoners of war, and so on and so forth. And in that book, and really in a lot of my research, I was very interested in looking at long-term trends in war. And one of the trends that I was looking at was why it was that we no longer see peace treaties that conclude interstate wars. And so this is, I think, actually especially interesting in light of President Biden's very recent decision to pull the United States out of Afghanistan by September 11th of this year. I'll be interested to see whether there's a peace treaty. And I'm not sure that there's going to be. And if there's not, that's kind of par for the course for how wars, especially wars between countries, end these days. Anyway, I had a paper, a manuscript that I had submitted to a journal for peer review on this question of why it is that wars no longer end with peace treaties. And as part of the peer review process, for those of you who might not be familiar, you get these reports from peer reviewers. And in this case, one of the peer reviewers really wanted me to engage with what was at the time a pretty recent literature on the decline of war. And so you see here the cover of Steven Pinker's book. Pinker is he's a psychologist at Harvard, and he's a kind of a public intellectual. And he wrote this big book arguing that violence is on the decline. And so this reviewer wants me to engage with this book, and I look over at my bookshelf, and it's this behemoth of a book. It's 800 pages. And, I was going to read it one day, maybe. And now I really had to read it. So I read this book, much of which is, the first number of chapters are about interpersonal crime. So homicide, how people treat their pets. That's not really what I work on. I'm not a criminologist. And so I have less to say about those. But then when you get to later in Pinker's book, he talks about war, both wars between states and wars within states, civil war. And now we're in my wheelhouse. And so he's making an argument that war in general is on the decline. And the data that he's using to make this argument is what you see on the left here, and that is a decline in battle fatalities. a decline in battle deaths over time. But what was really striking to me in reading this 800-page behemoth of a book was that there's just about one sentence in the book on medicine. And I hadn't done any research into medicine at the time. But it really struck me that at the same time, over the same time period that Pinker was arguing that war was on the decline, and he's really covering in the book a much longer time period than 1946 to 2008, which is what you see here. He's covering centuries, if not longer. The main metric he was using for making this argument that war was on the decline was a decline in battle fatalities. But with really dramatic improvements in medicine, it seemed to me that it was quite possible that what was happening was that war casualties were being shifted from the fatal category to the non-fatal category, from one column to another. And so I started to do some work looking at what are called wounded to killed ratios. This is exactly what it sounds like, the number of wounded compared to the number killed. And most international security scholars will tell you that the wounded to killed ratio is 3-to-1, full stop, because that has been a pretty stable statistic for a really long time. But what you see on the right-hand side here is an increase, that each of these dots is a wounded to killed ratio for a country in a specific war over time. And you see there's this real increase in the wounded to killed ratio. And I don't know if you can you see my cursor here? Okay, so you see this increase here? So this is around 1950, and Pinker starts at 1946. So if we were to draw a line going down here, there's a corresponding line in terms of the wounded to killed ratio going up here. So again, this just kind of underlines this idea that what's happening is that because of these improvements in military medicine, we have a shift in the columns that casualties are in, but everybody was focusing on fatalities and nobody was really focusing on the medicine. So, I published another paper on making that argument, basically pushing back at Pinker and the people who are making very similar arguments. And for me, one thing that really lingered after publishing that paper was thinking about the longer term costs of war as a result of these improvements, because as a percentage of those deployed, especially for countries like the United States today, we have many more people returning home having survived wounds that they would not have survived in the past. And I think about this in the following way, that when we talk about the possibility of going to war or using force, these decisions are usually framed in terms of a cost-benefit analysis. And the costs are typically broken down into two categories. One category is the human costs of war. And again, these are almost always conceived of in terms of fatalities. And the other category is the financial costs of war. But when members of Congress ask the Congressional Research Service, for example, to budget out to estimate the costs of war, the costs that they include are things like, how much does it cost to get a fighter jet into the air? How much does it cost to get a tank in the field, to feed people on the battlefield? They don't think about the longer term costs of war. And so this led to a book project that I'm working on, Military Medicine and the Hidden Costs of War, where I'm arguing that dramatic improvements in military medicine, and this book is just on the United States case, alongside historically the expansion of the veterans benefit system, have increased the long-term downstream costs of war in ways that we tend not to appreciate. Because again, we have many more people returning home as a percentage of those deployed, but with very serious injuries that they would not have survived in the past. And so they are bearing the human costs of war on their person, their families are bearing the human costs of war, and the government is paying for healthcare and disability. And I'm certainly not arguing that we should roll back the medicine, right? I'm not arguing that we should roll back the veterans benefits. But what I am saying is that if we want to use a cross-benefit analysis to decide when to use force abroad, then we have to get the cost part right. And I don't think we are. So in doing the work for this book, I've been reading a lot of history of medicine. It's quite disgusting, and I will not show you any of the pictures. I'll spare you all of that. But one of the things that's really struck me in conducting that research is that historians of medicine, who are typically focusing on one conflict, are very persuaded of a relationship between military medicine on the one hand and military effectiveness on the other hand. So they want to make the argument that militaries that have better medicine are more likely to be effective in lots of different ways. Now, one important difference between political scientists and historians is that political scientists like me tend to generalize. So, I'm not surprised that historians feel very strongly that the topic that they study is extremely consequential. And it seems to me plausible. There are lots of reasons you would expect to see this relationship. But it was something that I thought was worth investigating further, especially because even though there's an enormous literature out there on military effectiveness, surprisingly, it doesn't actually incorporate military medicine at all. And one of the reasons this is surprising is because one of the measures of military effectiveness is how many people die. And you would think that medicine matters, right, for that particular variable. So I'm working on this other project right now, looking at the relationship between military medicine and military effectiveness. And the first way that I'm looking at it, and this is from a paper with Pedro Corsi, some of you may know, is to look at, we're collecting data on countries, all countries in the world and engaged in wars in the 20th and 21st century, and collecting data on the quality of their military medicine, on the ratio of medical to combat personnel, on which side we think has the medical advantage in war. And what this chart on the right shows you is we're looking at a particular war. We're looking here at World War II, and in fact, a particular campaign, the Italian campaign in World War II. And we want to see what the effect of a medical intervention, in this case, the introduction and widespread use of penicillin, and what the effect of that intervention is on something called the loss exchange ratio, which is kind of how many people do I lose compared to how many people you lose. And so you don't have to worry too much about this, but what I want you to notice in each of these charts, the first two are the United States versus Germany, the bottom two are the United Kingdom versus Germany, is that there's a vertical line. And that's when you see this introduction of penicillin. And the loss exchange ratio really drops after the introduction of penicillin. Does anybody know why that would be? Anybody want to make a guess as to why penicillin has such a big effect? So I assume some of us have had penicillin in the past. Leah, did you want to?
I was wondering, does penicillin also prevent gangrene from being as aggressive?
It could, yes. Although it's actually not I'm asking this because I was a little bit surprised when I figured it out. Although when I figured it out, I thought, oh, of course that's it. Anyone else want to make a guess as to why penicillin matters so much in this particular campaign? Because we're not talking about we're not talking about 5 years, right? This campaign, it doesn't last that long. It lasts, a few months, really. So when we started this, I thought, well, when I've had penicillin and when my kids have had penicillin, it's because someone was sick, or I know that you have it to prevent infection after a surgery, and there are lots of surgeries that happen in war. And so I thought, okay, well then maybe that's it. But actually, when you think about it, while it's true that penicillin can have that effect and does, in fact, help in terms of preventing, say, post-operative infection, a lot of people who undergo surgery are out of commission for quite some time. And so they're not really the introduction of penicillin in those particular cases isn't really going to have an effect on the war. What matters is preserving manpower. And penicillin is an extremely effective treatment for sexually transmitted diseases. And there was just an enormous outbreak of syphilis in the US and British militaries during the entire war, but certainly during the Italian campaign. And so instead of being out of commission for 3 weeks or 3 months even, you didn't even necessarily have to stop your duties at all if you were being treated with penicillin. And that's what made the difference in this particular campaign. All right, so that's as gross as I'm going to get. All right, the other piece, or the other way that I think about the relationship between military medicine and military effectiveness is in terms of what's called soft power. sometimes. So, this example I just gave of the Italian campaign, that's hard power. That's people with guns and bombs on the battlefield. But militaries also engage in a lot of what's called soft power, where, you hear about this sort of hearts and minds approach, certainly in the context of counterinsurgency wars in Afghanistan and Iraq. And so they're, here what they're doing is they're trying to put on their best face to the local population. And so one of the things that military and medical personnel do is they engage in health diplomacy, right? They provide medical care to local populations in conflict zones. And a lot of times they do it, even they're deployed to areas that are not conflict zones. So in the context of a humanitarian emergency, or just in the context of a partner, right? So it doesn't even have to be an emergency or a war context. We see this kind of thing happening all the time. And one of the things that that I was noticing in the research was that it seemed like it wasn't just the US, but lots of other countries' militaries were doing this. And so I wanted to investigate this topic of health diplomacy in both the military and non-military context. And I say all of this, I give you this story in part just to assure you that I'm not an ambulance chaser, so to speak. I was working on health diplomacy even before COVID-19 broke out. So that's again, the sort of back to the bird's eye view. And before I go on, let me say that this is what I mean when I talk about health diplomacy. I think of it as international aid typically that can have one of two goals, and sometimes both at once: to promote health or to promote non-health related aims, usually foreign policy aims of a particular country. And so I've been looking at health diplomacy before COVID-19 and also, of course, during COVID-19. So lots of countries, as I said, engage in health diplomacy for different reasons. Cuba is actually a country that's been conducting health diplomacy and really has been at the forefront of this particular kind of aid and diplomacy for decades and is very good at it. There is an interesting broader literature on health diplomacy, but it doesn't include a lot of political scientists, or rather political scientists haven't included themselves in this literature very much. Much of this literature is really produced by public health experts. And I'm going to circle back to some of these interdisciplinary differences. Increasingly, though, I think what we're seeing in terms of health diplomacy is that it's becoming a forum for great power competition. And again, this was something that was happening even before COVID. Xi Jinping declared the creation of a health Silk Road in 2017 to accompany the Belt and Road Initiative, which is China's global investment strategy. And the United States has been very concerned about increased Chinese influence around the world, including in the domain of health. So along with Logan Stundle, who is a graduate student in the department, we've been mapping US and Chinese health diplomacy. And I know these maps are a little bit hard to see, but the thing that is important to notice is that in the top map, which shows you a slightly earlier time period, 2001 to 2007, you see a decent amount of blue and also this sort of greenish color. And those are colors where it's either mostly the United States or mostly China, not both, that are providing health aid to a particular country. In the bottom, you see much less blue and green. You see much more in the way of, this is called a chloropleth map, but much more along the lines of the US and China being in the same countries, right? So this has changed. They used to kind of be in different countries. Now they're in the same countries. And so just, statistically, when we've looked at this and plugged the data into a statistical analysis, what we find is that, so here this pink line is the likelihood of the United States providing health diplomacy to a particular country. And what we're interested in is whether China has previously provided health aid to that country. And so and it goes up very clearly. And what that means is that when China is there, the US shows up pretty soon afterward. China is also responsive to US health aid, but the slope is not nearly as steep. So one question that we're trying to figure out is is it the case that the United States and China are actually chasing each other? I mean, my hunch at the moment is that I think that the United States and China, when it comes to health diplomacy at least, are playing slightly different games. I think that the United States is engaged in a kind of knee-jerk competition vis-a-vis China, whereas China really is primarily concerned with with its investment strategy. Interestingly, and this is something that we don't have as much data on right now, we do see both the US and Chinese militaries also engaging in a fair amount of health diplomacy. And I think that may actually be a little bit more competitive than what we're seeing here. In other words, the slopes might be about the same if we were to look at US and Chinese military health diplomacy. All right, so let me move on to talk about health diplomacy during COVID-19. For me, as an international relations scholar, the big question here is, why haven't we seen more robust global cooperation around COVID-19? It's a global pandemic. You clearly need global solutions to address this problem. And yet, I don't think anybody is really pointing to the WHO as being super duper effective in addressing the pandemic. On the contrary, the WHO has been on the receiving end of a lot of criticism, partly because of its relationship or how it's handled its relationship with China. But I think that, you know, we're being a little bit hard on the WHO, and the reason is that the expectations, I think, of the WHO are too high. The WHO was never designed to be able to intrude upon state sovereignty, and you would need to be able to intrude upon state sovereignty to accomplish the kinds of goals that people would expect are expecting, it seems, of the WHO. The WHO is an intergovernmental organization. It was designed by states, and states are not going to design it in a way that really allows it to infringe upon their sovereignty. So what we have been seeing in the absence of a robust response from what is the main global public health institution is a shift to regional and bilateral health diplomacy. And this is actually in line with health diplomacy even prior to COVID-19, but in response to past outbreaks, past pandemics. You know, so if you go back to SARS in 2003, the WHO actually did a pretty good job, but the WHO was even weaker in 2003 than it is now. And so it got high marks, but the bar was pretty low. But once you move on to, say, H1N1 in 2009, then it's really the Pan American Health Organization that is doing a lot of the heavy lifting. Ebola in 2014, you would think that the WHO would step up, and there is a global response led by the United Nations called UNMIR. But this response is, in fact, really being led, it's ostensibly being led by the United Nations, but it's really being led by the US and its allies. And so again, you see, so in the case of H1N1, you see a regional organization stepping up. In the case of Ebola in 2014, you see more in the way of, you know, bilateral or even multilateral health diplomacy, but not effectively channeled through a global public health organization, to be sure. And during COVID-19, I think we're also seeing a lot in the way of both regional and bilateral health diplomacy. So I think, you know, the African case is a very interesting one, where the Africa CDC has gotten, you know, relatively speaking, pretty high marks, notwithstanding all of the issues that are being raised right now, which I'm happy to talk about the Johnson & Johnson vaccine. You know, the African Vaccine Acquisition Trust recently negotiated a pretty big contract with Johnson & Johnson. And this was the preferred vaccine for the continent because it doesn't require cold storage and because it's a single shot vaccine. So it's a lot more convenient, it's a lot more practical for lots of reasons. And it's, you know, in any individual African country was not going to be able to negotiate a contract on those terms that the regional organization was. Europe, for all its problems, has actually done a pretty good job on a regional basis in terms of managing the pandemic. You see travel bubbles between Australia and New Zealand, between Hong Kong and Singapore, and so on. So there's a lot going on regionally. The United States, when we have unused AstraZeneca vaccine, we give them to Mexico and Canada, not to Brazil, which has a much higher disease burden, right? So there are lots of reasons for this focus on regionalism. Among them, the fact, just has to do with the confluence of public health and geography, because pandemics, of course, viruses rather, don't observe borders. And so you want to help your neighbors in order to help yourself. But we're also seeing a lot of bilateral health diplomacy during COVID-19. We saw this last year with what's so-called mask diplomacy, especially by China and also by Taiwan, and right now in the form of vaccine diplomacy. And this is something that, again, I'm happy to talk about. But I don't want to. I want to leave lots of time for conversation. But I'll just go over like a little bit in terms of what's been going on, just to show you a little bit of data for health diplomacy in the context of COVID-19. So this is from the Council on Foreign Relations, and I think it's really interesting to think about which countries are getting which vaccines. And to me, it's fascinating that it's the upper middle income and lower middle income countries who are receiving the Chinese vaccine, which very recently, a very prominent Chinese scientist essentially admitted that the Chinese vaccines might not be very effective. And that to me is very concerning. If this is the vaccine that's available on the market for much of the world, because they can't get Pfizer or Moderna, and it's not effective, and that's going to make the pandemic last longer. The Russian vaccine is also one that's been going to, all three of the four categories here, everybody but the higher income countries. But the Russian vaccine, they're having real supply problems. So there's interesting questions, I think, about who's getting which vaccine and why. Now, a lot of these vaccines are being sold. A lot of them are being donated. So it's also interesting to think about who is donating the vaccines. And you see here, China's really all over the map. China's doing a lot of vaccine donation. The United States is mostly donating money, not vaccine. But the vaccine is much more valuable right now because it's so hard to get on the market. And then I think, and I'm going to end here with this chart, sort of comparing disease burden to vaccine donation. Now, I said that earlier on that there aren't a lot of political scientists who study health diplomacy, that this field is really dominated by people who work in public health. And I've noticed that there are some really important differences between how public health experts and political scientists tend to approach these questions. And the difference has to do with whether you're focusing on what is or what ought. It's obviously we need to know what is the morally and ethically right thing to do, right? So, and I put this chart up here because I think it raises some interesting questions there. The highest disease burden has been in Europe and North America, but these are also the world's richest countries. So should they be receiving lots of vaccine donations? So I'm not sure that disease burden is the right metric here to use in terms of thinking about ought in terms of vaccine donations. But I think that it's also really important to understand the answers to questions like, why is it that the WHO hasn't been able to rise to the challenge of addressing COVID-19? So that's a question about what is rather than what ought. And this is something that I find interesting kind of in thinking about the interdisciplinary topics like health diplomacy, where Some people, I come into the room thinking about, why is this the way this is? It's what I want to understand. Whereas a lot of the public health folks are making advocacy arguments, and I'm not at all criticizing them for making those advocacy arguments, but I just want to underline the difference in what they're doing and what I'm doing. So I'm motivated actually by a lot of the same things that they're motivated by, but our approach to the problem is quite different. And I think part of the reason that I think about it or approach these problems the way that I do is because I want to understand why suboptimal outcomes happen. And because I think understanding that will help us, or can potentially help us, move beyond some of those suboptimal outcomes. So there's this interesting division of labor here. And I'll just end by saying that in terms of thinking about this is versus ought dynamic, this is something that I notice not just with folks who study public health, but I think also with folks who study climate, where climate scientists are very clear on what has to be done. And they find it very frustrating when they kind of bump up against the politics of it and don't necessarily have a good solution. So this is, I think, the kind of thing that political scientists can really contribute, can do to really contribute to these debates and hopefully help mitigate these global problems. So I'm going to stop there and look forward to your questions. Thanks everyone for your attention.
Thank you, Dr. Fazal. That last point you make about kind of the parallel to climate and the environment is really striking, because I remember in our class over the summer, like having a minor in environmental policy and science. For me, that was something that really, that I felt was a really recurring theme, just with some of the issues of misinformation between the two, between international aid and kind of in terms of discussion, whose responsibility is it to step up or provide more?
Yeah, I mean, I think that even though I'm spending all of my time right now on COVID, it's really climate that's the existential crisis of our time. We'll get beyond the pandemic one way or another. Although I will say that my students, so Andrew took this class, the International Relations of COVID-19 with me last summer, and I'm teaching it again this summer. And Khalid, who's here, Zara, who's here, took it over the summer too. And Khalid, who's here, is taking it this semester with me. One interesting question, and I'd be curious to see what people think about this, that a student raised in class, I'm digressing a little bit here, is how will we know when the pandemic is over? And I was thinking about this in terms, so we have a session in the class on the war metaphor and COVID-19, because you see this used all the time, frontline workers, the war against COVID. And I think that students tend not to think that the war metaphor is all that helpful, that maybe it does more harm than good. And at first, when I thought about this question of how will we know that COVID is over, I thought, well, you can't have a peace treaty with COVID, right? That's not, so maybe that's a failure of the war metaphor. But then I thought about it some more and I realized, the way that we put together our data sets on armed conflict are such that in order to identify the end of a conflict, you have to be below a threshold in terms of how many people die. And that might be the kind of metric that we use to identify the end of COVID, or the end of the pandemic, at least in certain areas. But I think it's going to go up and down for a while before it is really down.
I agree with you on that point, Nisha, because if you look at polio, like the way we talk about polio in the public health world is that polio is eradicated when it's actually endemic to 3 countries in the world. So I would agree with you that it'll probably be a threshold type mechanism.
Yeah, I think that's right.
Nisha, can I ask you a question?
Yeah, of course.
Well, first, thanks for this. It was really interesting. Is an explanation for the anemic cooperation maybe one, maybe not at the international level, and that's vaccine nationalism and in general folks prioritizing their national interest over what would be the answer to the problem, and that's some form of global cooperation, thinking that they can stop the virus at their borders, maybe. And then with great power competition, are there any sort of indicators that the US, for example, when it gives health aid, attaches strings to it? Say, we'll give you this, but don't do anything with China, or like they would do maybe with military aid or something like that. Or do we see folks in health diplomacy thinking in these kind of terms, or do you think it's maybe more of a implicit reaction to China's influence? In other words, is the US being quite articulating that the US should challenge China in these ways, or is it something that's maybe a little more subtle than that?
So, Robert, you were breaking up a little bit for me. For the first question, you're asking, is vaccine nationalism the answer to why we don't have global cooperation? Is that right? Yeah. So I think that, yes, I mean, empirically, that's what we see, right? That there's a lot of vaccine nationalism and not much in the way of global cooperation. And I think that this was predictable, and people were predicting it last year before we had the vaccines. But I think that what it also what it's important to think, it is analogous in a way that Andrew was just talking about to climate, where it's just a huge collective action problem, because we would all be better off if vaccines were distributed more widely. So Dr. Tedros, the Director General of the WHO, the WHO, and Henrietta Fore, who's the director of UNICEF, put out a call to vaccinate healthcare workers globally. So the idea would be that for a country like the United States, once we are done vaccinating our healthcare workers, then you distribute the vaccine globally. You either sell it or you donate it to vaccinate healthcare workers everywhere. And so that way you preserve health capacity in a way that's going to have not first order effects, but second order effects that mitigates the pandemic and perhaps lowers the likelihood of the kind of variants that we're seeing that are going to make the pandemic last much longer. So there the argument is that it's, everybody is better off if you cooperate globally in the same way that you do with respect to climate. But of course, the political incentives go in exactly the opposite direction. And that's why we see what we see. But to your second question about what US and Chinese health diplomacy look like, so I have a few thoughts. So one is that it's really interesting. So Chinese health diplomacy usually comes in the form of loans. But it's loans that are really different from the kind of loans from the International Monetary Fund that countries have historically gotten. It doesn't have strings about, whether you have to make changes to your political system or they're not onerous loans in terms of these, what's called conditionality, or these strings that might be attached to them, but they come due. And countries can't necessarily pay them. So they're onerous in that respect, whereas the US is more likely to give grants. But when it does give loans, it is more likely to have these strings. I do think, though, that the US is pretty clearly responding to China or thinks it's responding to China. Again, I'm not sure that the US and China are playing the same game here, but I think a really clear example of the US being worried about Chinese health diplomacy is the initiative from the Quad, the United States, Japan, Australia, and India, to set up a new vaccine facility to develop and distribute vaccine in Asia, which is a region of the world that hasn't been hit particularly, with the exception of India right now, hasn't really been hit particularly hard by the pandemic. If you really want to help people, again, send it to Brazil, send it to Turkey, send it to Iran, but that's not what's happening. So, I think the US is very clear that this was to counter Chinese influence also. Sorry, this is a depressing answer. Go ahead, Khalid.
First of all, thank you for the presentation. I enjoyed it. And also, we can't hear anything in the background. So
Oh, good.
this is just like what I was thinking about in relation to the observation that vaccines are not going to countries with the greatest caseload. And this is probably like a very realist and like brutal POV. But I was just thinking, if vaccines were donated to countries with the highest caseload, there seems to be like there seems to be an incentive almost to mismanage the pandemic so that they can receive vaccines and get over it on the other side. Like,
Mm.
for example, vaccines were donated to Brazil at high levels. The Bolsonaro seems to be really mismanaging the pandemic, and I don't know. I'm not saying he should be held responsible through the death of Brazilians, but maybe I don't know. Maybe sort of an IMF austerity style strings attached to these vaccine donations, where they would have to manage the pandemic in a certain way in order to receive these vaccines.
Yeah, I mean, I think it's a really interesting and important point, Khalid. And it's something that when I first saw that chart that, it's kind of updated on a regular basis of which countries are getting which vaccines. Josh Busby, who's a professor at University of Texas at Austin, who also works on global health, on Twitter, we were having this conversation, and he was really interested in whether vaccines were going to the countries with the highest disease burden. And my reaction was a little bit similar to yours, Khalid, in that I was thinking, well, I mean, that at the time, that's like the US and the UK, like, do you really want to reward bad behavior, basically, in this case? And also, these are really rich countries. So I don't think that there's much of an argument for making donations to the US and the UK. But I think that, to me, Khalid, the way that I think about your question is that there is, not in all cases, but in a lot of cases, there's some other factor that's determining why countries are doing so poorly. Not for all countries, but I think Brazil is a really good example of that. The United States, frankly, is a good example of that, potentially the United Kingdom. Chile is maybe not a good example, right? Where in Chile, they are vaccinating at a very high rate, but they also have a very high caseload. And my sense is, without knowing this case particularly well, like on a surface level, I feel like this is a country that's been trying to do a good job in managing the pandemic. And so I think it'd be really, I would have a hard time ethically saying that we should have strings attached to vaccine donations. I just don't think that that's something that you can do, because it is an emergency, right? That's like saying, there's a tsunami and you never really built the infrastructure to deal with the tsunami, and we're not going to come help you, right? Even though we know you're going to do a terrible job after we leave, right? Or we think it's quite possible. I just don't think that that's the right approach in this case. But, it is concerning that there is a reason why some of the countries that have done so poorly, and that reason has to do with politics. So Bolsonaro, like Trump, like Johnson at the very beginning, not taking it very seriously.
I was a little bit curious about just kind of your interpretation, or what like your perception is on sort of the broader nature of Chinese aid and direct aid to other countries through its Belt and Road Initiative. Because I know like really there are a lot of politicians kind of like point and shout from the US at least that it's somewhat predatory behavior, that China's entrapping other states in debt. And then on the other hand, there are a lot of scholars and like pieces that have been published across foreign affairs and CSIS where they conclude that Chinese aid or Chinese loan really isn't that much more politically motivated than the US aid. So I guess I was just kind of wondering what your general perception was along that discussion, and then maybe more specifically as it relates to the pandemic, how COVID-19 is possibly going to change, or how might it promote public health diplomacy to take a greater role in the Belt and Road Initiative and through its health initiative in the future?
So I tend to agree with Jessica Chen Weiss, who's a professor at Cornell University, in her approach to thinking about Chinese foreign policy. And her starting point is basically that this is Chinese foreign policy, really, and Chinese domestic policy too, for that matter, is really driven by the desire of the Chinese Communist Party to stay in power. And so it's not necessarily, I mean, the idea of improving China's image on the world stage is a positive externality if it's something you can do, but it's not the main aim of all of this aid. That it really is, the Belt and Road Initiative really is an investment strategy in order to continue to improve China's economy. I have even heard, although I'm not an expert in China's foreign policy nor in China, but I've heard China experts make the argument that a big component of the Belt and Road Initiative is essentially a jobs program for Chinese, because there's a surfeit of labor in China, and so they're effectively exporting labor abroad. So again, it's not so much about what your policy toward a particular country is. It's about where you can make investments that are going to make you money, employ your citizens, and keep you in power. I think that, with respect, I will say also that there are, one of the things that I have heard is that there are oftentimes a lot of concerns about the quality of goods and services provided by the Chinese, especially certainly I haven't looked at another issue areas when it comes to health diplomacy. So for example, last year when China was engaged in a lot of mask diplomacy, there were a lot of countries that were very grateful to receive the personal protective equipment that China was saying, but then other countries saying this is substandard stuff. It's not really going to work at all. And I think that we're potentially seeing, I think the vaccine story with China is really interesting, right? Because at the beginning, or recently anyway, they were kind of casting aspersions on the mRNA vaccines. Now in the past week, you have this I think he's kind of analogous, I'm not entirely sure, to Rochelle Walensky in the US in terms of his role in China. This scientist saying, well, maybe the Chinese vaccines are only about 50% effective, maybe they're even a little bit less. And you have to, the vaccine, for the WHO to adopt it for COVAX, for example, it has to reach the 50% effectiveness threshold. So again, this is this question of quality. And you hear this with respect to, infrastructure that China builds in the countries it invests in as part of the Belt and Road Initiative as well. So I think that it's, I think, Andrew, one way to think about your question is what the effects are of this health diplomacy in terms of global politics, right? And again, I'm not an expert on China, so I don't want to speak to what the effects might be in terms of Chinese domestic politics. There have been a lot of surveys that have been conducted about the public opinion in countries that receive US and Chinese health aid. And I haven't yet completed, and I'm kind of in the middle of a literature review of these surveys, so I can only report on, maybe I'm a third of the way through. But to the extent that it's representative, I'll tell you what I found so far, which is that it doesn't seem to work for China for some reason, right? So if you are in countries that receive a lot of Chinese health aid, it doesn't improve local attitudes toward China on average. It actually ends up improving local attitudes toward the US, even if the US isn't there delivering health aid. And I'm not entirely sure what's going on there. It might be because they're not employing that many people locally or employing them in a way that's sustainable. It might be because of the perceived quality of Chinese health aid. I'm not sure, but that's my read to date anyway of what's going on in terms of the effect of this, whether they're insofar as it's a soft power campaign, is it working? I think it might be working for the US, but not so much for China. Go ahead, Sarah.
No, thank you again for speaking with us today. I kind of have a question regarding surveillance and sort of, are countries like China and the US building surveillance capacity in these other countries? Or like sort of, how are they coordinating that at this moment?
Yeah, so this also goes to Andrew's question about how China and the US might fare in the pandemic. And with apologies to Khalid, who's going to hear this kind of reprised on Monday when we talk about US, China, and COVID-19. There are a couple of sets of questions here. One is whether the pandemic is making it seem like authoritarian countries provide a better model than democracies, because some of the authoritarian countries seem to have done much better in terms of managing the pandemic. And then a related question has to do with the idea of exporting surveillance technologies, which is something that China is doing a lot of. But again, I don't think so there's a lot of suspicion that China is exporting these surveillance technologies as a part of trying to export this authoritarian model. I'm less persuaded by that than I am by the notion that it's just economics. It's primarily driven by economics. I mean, maybe they'd be happy to export an authoritarian model, but I don't think that that's the main goal. Yeah. Andrew?
I had a brief question that was kind of related to privacy. So like, obviously in a lot of nations now, or at least like for China early during the pandemic, if you wanted to travel, or travel to some different cities, there's like a form of verification, like the QR codes. In Israel, they have their own app for attending concerts or something. And pretty soon the conversation's going to enter. I mean, I know a lot of companies are going to stay virtual and stay remote and just distance for the practicality and convenience. But when there really is a massive transition or shift towards going back to in-person working, what's sort of the ethics of requiring a vaccine to work, like needing a vaccine to get a job, especially when people who may need the job the most have the least access about that? Is that, I'm guessing just from my own perception, that's something that might kind of be more prevalent within the private sector, within individual companies, but is that something that our own government would be willing to do? Or just how might countries respond differently to such a policy?
Yeah. So, I mean, this is sort of the question of the day, right? These sort of vaccine passports to cross international borders, to go into your office, things like that. So, I mean, I think that it would not be ethical to require vaccination if vaccination is not available, right? So that's just to one of your questions. You can't say you have to meet this bar that's impossible to meet in order to get a job here. I think at least in the United States, I think that in a couple of weeks, we're going to have more supply than demand, right? So I don't think that that availability is going to be the issue, and the vaccines are free, right? I mean, if you have insurance, then your insurance will cover it, but if you don't, you can get it for free, just like the testing. I think this is something that's more likely to happen at the level of the private sector or individual organizations than at the level of the federal government. But, you've all been to college, you had to fill out immunization forms. What's happening with the military in the US, I think, is really interesting, where there's a lot of vaccine hesitancy in the military, but that's something that military personnel can do because the vaccines are being used under emergency use authorization. Once they're like approved fully, then my understanding is that then the military can require military personnel to take them as being part of the military. So I think that this is a case where public health bumps up against individual rights and preferences and beliefs. but there are lots of things that we do for public health and have done for a long time. While there is a vaccine and the anti-vax movement in the US, it has historically, at least thankfully, been a minority. But I think that it is going to be required you are going to have to show proof of vaccination to do lots of things domestically. I think the issue is going to be, at least in the near term, the fact that vaccines are distributed so inequitably globally. And so Tanzanians won't be able to go to France, but French might be able to go to Tanzania. And then another really interesting way that we're seeing this play out is that at least a couple of weeks ago, China was saying, if you want to come to China, you have to show not only proof of vaccination, but proof that you received one of the Chinese vaccines, right? Which, especially given the more recent news that may not be very effective vaccines, is really problematic. So I think that those things are ultimately going to get, I think the sort of which vaccine will get sorted out, but I think it's going to be a very long time, and we're going to see a lot of inequities along the lines of what you were mentioning, Andrew. In the meantime, internationally, although less so in the US, just because I think that the issue in the US is that the vaccine hesitancy is like in these particular political and demographic pockets. And so that's going to be a challenge to address, but it's not, I think it's less at this point. I mean, it's about inequity in the sense that there are people in marginalized communities who are understandably very hesitant to take the vaccine, but I think that there are a lot of efforts being made to make the vaccine available very widely. So it's about the gap between, like, the inequity in the US is about the gap between supply and demand, but the issue is on the demand side, I think, more so at this point than the supply side, or will be in at least a month or two. So I know we're just about at time, so let me just ask one question of all of you, which is, I'll be bold and assume that people are going to get vaccinated. So my question is, and if you don't, I'm not going to call on people, so you can just, jump in, because I don't want to make anybody uncomfortable. But what are you going to do 2 weeks after your second shot?
Get a haircut. I'm dying for a haircut. Yeah.
I'm getting my first just about in 2 hours actually today, but I really haven't thought that far. I'm surprised that this first one came up as soon as it did. So yeah. I don't have a correct answer for you, Dr. Fazal.
That's okay. But you should think about it. Like, it's sort of like getting out of jail, right?
I'm going to hug someone. I don't know who yet, but I'm going to hug someone.
Maybe one of us.
Outside of my household. I'm very excited about it.
Yeah, that would be nice.
That's exactly what I did. I got my second dose a couple months ago, and as soon as my best friend got vaccinated, we hugged, and it was great.
Oh, that sounds so nice. Looking forward to that.
I've been doubly vaccinated for more than 2 weeks, but nothing has changed. My habits are all the same. I haven't celebrated in any kind of way yet. I'm waiting to feel the urge.
Yeah, I'm a little bit worried that, I mean, I put myself in this category too, that we've all gotten so used to being hermits that it's just like, now we're in this groove, and it's going to be really hard to, Andrew is bringing this point up that a lot of companies are going to go virtual now, and so now we're just going to stay in our houses forever.
And they're like parents, like their employees who are advocating for that too. Like, hey, I like staying home actually and working all day. I might not like some of the broader aspects of social distancing and quarantine, but this is a generally higher quality of work or labor than I may have been experiencing before.
Yeah, I think a lot of people really prefer it and they appreciate the flexibility. So I think the pandemic, there will be some positive externalities, which is a good thing. It would be nice if it's not all bad.
I'm looking forward to kind of just being more comfortable around people and getting rid of that anxiety that, you know, you may get it.
Yeah.
It was funny because like before I got like both my doses, I like went to a friend's house to drop off food, and I was like, oh my gosh, a human being that I know, that I'm not just like looking over like the computer, like I'm meeting with them. So I mean, I've gotten the second dose. I think my main plans are just to again sort of stay in until I guess school starts in person possibly, and then get sort of my DMV driver's license, all of that stuff sort of figured out because I'm a bit behind.
Yeah, I'm gonna get my glasses tightened because they're just they're so loose, and I've been doing yoga at home for a year, and my glasses just every time I go into downward dog just fall right off my face onto the floor. So that's going to be a big improvement in my daily life. Well, thanks everybody for taking the time today.